Good afternoon, everyone. These lights are shining in our eyes, so that's why the squinting up here. I'm Jerry Vaccaro. I'm a psychiatrist by training. Have been at this for a while. We're going to talk today about behavioral health outcomes, really focused on clinical outcomes. And then I'll introduce our speakers in a minute, in turn. So my comments are going to be brief, and really what you're going to get from Doctors Daly and Gilbert is a sense of kind of where the field of behavioral health clinical outcomes management has been and where it's likely to go. Like I say, started off quite a while ago in psychiatry at a time when psychoanalysis reigned supreme. And I commend to you a New York Times article that actually appeared today about outcomes measurement and management. And when I trained in the days of Freud, outcomes weren't important. And literally, I was told, I was frustrated because I was told that you didn't really focus on the outcomes because it was all in the process of treatment. And that outcomes couldn't be measured and this, that, and the other. And I used to sort of be a pain in the neck with my supervisors and talk to them and say, well, I don't manage diabetes that way as an intern. And the analogy I like to use with people is to say that if you had some chronic disease like diabetes and you went into your primary care doctor and the doctor looked at you and said, I get this sense that your blood sugar has been high for the last few months, so I want you to increase your insulin and do a couple of other things and take this other medication, you'd leave, because you just don't manage healthcare issues that way. But in behavioral health, it's been that way for a long time. And beginning really about 20 years ago, some innovations that had occurred in research world where people actually did measure behavioral health, psychological, addiction types of outcomes in research settings to prove that certain therapies work. But those tools that were used never really migrated into clinical practice. And so what you had was this dichotomy where in a research world, you could say, okay, cognitive behavior therapy has an effect size of 0.82, whereas psychodynamic psychotherapy doesn't seem to have as strong an effect, so therefore CBT or cognitive behavior therapy is more effective. You could have those conversations in a research world, and it had not at that time translated into clinical practice. Beginning around 20 years ago, so I've traipsed through academia doing that kind of research, and then into managed care, where I was CEO of a string of managed care companies like the Booz and Hisson Come now, United Behavioral Health, which is now Optum, Pacific Care Behavioral Health. And I asked the same question. I said, well, how can we go to our customers and not argue to them that because of us, their members, employees, family members are getting better clinical outcomes? It's a stupid thing to try to represent to them other outcomes, but not that. And so what we did back at Pacific Care and then at United was plant in the kinds of tools that you're going to hear Doctors Daly and Gilbert talk about today to actually measure clinical outcomes and prove that what we do works. And I remember the first time we did it, we replaced, how many people here actually are providers of behavioral health care? Okay, fair number of you. Don't know whether you remember the days of managed care where they would dole out with a little eyedropper the number of outpatient sessions you could have. But this was at a time in managed care where my company, before I got there, would dole out 5 sessions at a time. And you'd have to call in as a provider and say, well, my patient is sick and I need another 5, and we dole them out. What we did was we planted in a system instead that did away with that administrative burden and instead had clients, filling out patient self-report tools that were used in research settings that you'll hear about today, that measured clinical outcomes, and we went into the background at the managed care company. So no more phone calls, no more authorizations. It all became automated, and we built what today people refer to as AI, but back then clinical algorithms, so that we would take the data in, we'd chew up the data. We'd say, okay, this patient is really getting sicker. At the end of the road, we want them to get well, so therefore, we're going to reach out and talk to a provider to do some of this. So anyway, so you fast forward the tape. I would call that sort of outcomes management 1.0. And I'd like to think that we've traipsed through 2.0 and 3.0 at this point. And that's what you're going to hear today. We'll start with Dr. Daly, who I'll introduce in a minute. She I'll introduce her now. Dr. Kate Daly is the medical director for interventional psychiatry at APN Lodge. I've been associated with APN for 4 years, I guess, about 4 years. Served for a brief period of time as their president, where I planted in the system that you're going to hear about today. It's referred to as ACORN. Fabulous system, measures clinical outcomes, and you'll hear her. I won't steal her thunder, but she'll talk about the very positive individual clinical outcomes, group outcomes, and then the impact that they've had on provider performance. So in other words, you want to be able to show that your patients get better and that your clinicians, your providers are doing a better job as well. Following that, Dr. Deja Gilbert, who is the CEO at Harmony Health Group. Is that the official now? No more Harmony Recovery. Harmony Health Group. We'll talk about the plans we have there and the early implementations that we have there with a system that's now called U on the open market, Y-O-U-U, and we're calling it Harmony Connect. And that one, that's kind of what I'd like to call 3.0, and Deja will talk to you about that and talk about some of the additional things that we've done or they've done that enhance the measurement of clinical outcomes and add to it measurements in what I would call the healthcare ecosystem that our clients and patients live in. And I won't steal your thunder. I'll let you talk about some of the innovations that some people will find scary, right? But I won't tell you why. And other people like me who geek out on this sort of thing find really exciting in terms of being able to positively impact clinical outcomes with our clients and our patients. So without further ado, Dr. Daly, I'll turn it over to you and let you talk a little bit about your programs there. And by the way, I'd prefer to keep this kind of interactive. And so if the two of you are okay with it and people have questions, raise your hand, I'll watch, and I'll try to call on you if I don't get blinded.
Thank you. Yeah, I would love for this to be more interactive. I prefer conversations instead of talking at people, so feel free to ask questions as we go along. So I'm the medical director at All Points North. It's a behavioral health company. We started with a residential treatment program just outside of Vail, Colorado, and we've expanded to offer multiple levels of care from partial hospitalization programming, IOP, OP, all the way to telehealth as well. And so pretty early on, we implemented ACORN, which is a collaborative outcome resource network. And this is a large data set that encompasses information and data from multiple organizations. So currently, the data set itself has just over 3 million patients from about 3,000 different providers. And it is mostly self-report and self-assessments from the patient, but also tracks along with those outcomes their demographic information, diagnoses, as well as kind of overall functioning. And the goal of this, of course, is to increase the value of mental health services and mental health systems at large. So the main tracking data point that's used is called the Global Distress Tolerance Score, and this encompasses 4 different dimensions. The first is self-report of symptoms from the patient, and the questionnaire largely takes from our PHQ-9 and GAD-7, which are self-assessment questionnaires that are used with primary care providers as well as mental health providers. It also tracks kind of day-to-day functioning measures, social functioning, and various risk factors for patients. One of the interesting things about ACORN is that it tracks therapeutic alliance. And we know in the clinical world that therapeutic alliance is actually the largest predictor for positive outcomes. So not the type of therapy you're doing, CBT versus psychoanalysis, for example, but really just the alliance between the patient and therapist. What's interesting is that the best outcomes we see are when a patient reports sort of okay-ish alliance in the beginning. There's some room to improve. And then that alliance increases over time. I think if you have clinical training and you think about it, it's not super surprising that we find that the patient who from the very beginning says, I love my therapist and I feel extremely close to them are most likely sort of over-reporting that positivity and being polite. When there's some room to improve in terms of the alliance, then you get to use that as a tool, essentially, in the therapeutic process. It leaves some space for conflict, which you can then work through with your patient, for example. And so all of this data is brought together, and this is just a snapshot of an example of a client data set. I think
It's on the side.
they're over there.
Huh?
It's on the sides.
Oh, it is?
Yeah.
Oh, okay.
So yeah, this is an example, just snapshot of a client data set. So you can see tracking the GDS or GDT over time along with therapeutic alliance. The purple line shows the kind of positive predictor of where the patient would be, and then in over real time, how the patient's done over time. I think, so in terms of using this interactively with my patients, I've found it extremely useful. I think even for patients, sometimes it's hard to describe how we're doing, how we're feeling, and if we've really changed over time. There's an interesting phenomenon in psychiatry that we often talk to our patients about where people around them notice they're doing better before you feel it. And I think some of that has to just do with the disconnect that's had to happen over time. If you have been sitting in severe depression for years and years, a coping mechanism would be to disconnect from that and kind of numb yourself to it. And so I, more often than not, have family members, support systems, telling me and patient, no, they really do, they're starting to feel better before the patient typically feels it. I think similarly, I've just had the experience a lot of times with patients in TMS or transcranial magnetic stimulation, which is one of the modalities that we're using, where by the time they get to TMS, they're so desperate to feel better. There's like this sense of urgency around it and not a lot of patience for waiting, which is completely understandable. And they'll say, like, I just don't feel better, I don't feel better. And what's really interesting is I, over and over again, have been able to pull up their PHQ-9s, their scores, and show it to them and say, but look, you actually reported from 3 weeks ago your sleep is slightly improved. And what's happening is they're making these small improvements over time. It's really hard for them to track the significance of them, but when you can show them their own data, it's really meaningful for them. This also allows you to compare providers, so you can take a larger, like a therapist's, their patient group, for example, and then compare how they're doing amongst their peers and colleagues. And then all of this data sits and is pulled from, like I said, 3,000 different organizations. So we can also compare ourselves as an organization as a whole against all the other organizations using ACORN. And this is important for a lot of reasons. I think it's important to do an analysis of how you are functioning as an organization globally, how your patients in various levels of care are doing as a whole. And you can show that the way you're providing care is leading to greater outcomes compared to other treatment facilities.
So, do you mind if I ask a question? Yeah. How do providers respond to this? I mean, do they embrace it immediately? Do they use it to get better? What do they do?
I think where we were initially was actually a lot of fear around this, because you are relying on the patient's self-assessment. And many of us as providers have had experiences where no matter what you do, the patient's angry with you, right? Or there's this fear around, well, if I don't, like we're in almost creating a customer service situation, so if I don't give them what they want, how will that reflect on, I'm actually providing good care, but what if that doesn't show? I think over time what we're realizing in reality is that those fears are largely unfounded. Of course, you're going to have a few patients that may fall into that category, but overall, people want to get better, and they're coming to see you because they want to feel better. So they're also motivated to get better. And I think this is just extra information that we can use for ourselves as well. The other thing is that one of the positives for this being a self-assessment and it being detached from the actual appointment or interaction, because they're just going into an app and doing this themselves with an app, is I think you actually get more reliable information. They might not tell you in your appointment unless you ask a few times in various different ways, are you really no longer having thoughts of self-harm, for example. But when they have that disconnect, they don't have to look at the person and answer the question. Right. I think people overall answer more honestly to it. So you just have more objective data that you can use.
Yeah, and there's good evidence that medical error rates, if you want to frame it that way, come down when you use systems like this. So you reference reporting of suicidal thinking or self-harm thinking, that those kinds of things, when you move out of the don't ask, don't tell environment and you get patients to reliably report, and you as a therapist ask, there is good evidence to show that that concordance improves clinical outcomes. Now, what about inter-provider efficacy? I mean, have you been able to gather data to show that this one's better than that one, better than the next one, or that they all get better at the same rate? Any of those experiences?
In terms of, or in comparing?
Yeah, so therapist A versus B.
Yeah, I mean, I think as a supervisor and director, you do look at that, because you're wanting to think about, is there something going on for better or worse, like overall programmatically, or is there something with this individual therapist? Is there something they're doing that I should look at, and then provide a space for them to speak to their peers about how they're doing something because it's working really well.
Okay, cool. I'm done with questions.
Okay.
Any other comments or questions for Kate, or were you done? Or?
Yeah.
Okay.
Yeah. We can keep.
Because then I'll bring it around later too, because having come out of the payer world, I have some questions and interest then in this latter question, is can you really discern good programs from not so good programs, or from exemplary programs? And it sounds like your experience has been that you're able to compare your program and therapists with the thousands of other therapists who participated in this project.
Yeah.
So. Sure.
What does the data tell you about telehealth in terms of its
Within our organization, we again have really good outcomes happening with telehealth, and I think it's also important to continue to basically be tracking these outcomes across all levels of care. Overall, I think it's important to continue to have a really astute clinical lens on that, because telehealth can work really well, and I'm a proponent of telehealth because it helps us increase access for people, right, that otherwise wouldn't have it. But I think telehealth needs to be thought of as its own level of care, and people need to be appropriate for that level of care as we think about kind of every other level of care that we've established.
Yeah. And actually, there's a body of evidence, Richard, coming out of England, where people have been interested in studying particularly CBT, cognitive behavior therapy, and comparing face-to-face and telehealth or web-enabled approaches. And some of the early evidence, well, all the evidence shows that they're equally efficacious given what you say, that it's the right level of care, et cetera. And there are a couple of studies that came out in 22 that appear to show that telehealth is superior to face-to-face therapy. So I think the story is being told. I think Kate's right. You have to attend to, are they at the right level of care? So somebody, for example, I'd question that somebody who needs containment in a residential or an acute inpatient setting, might not be appropriate for telehealth. Whereas if you deal with that, it appears that telehealth is highly effective. So, yeah.
How are we able to track therapeutic alliance?
Yeah, talk about that.
How are you able to track therapeutic alliance? And one question, I work in the, I'm a therapist in substance use treatment, and a lot of them want to say that they're doing better so that they don't get the treatment, and a lot of times they would relapse because they're not ready for that level of care. They don't want to go to IOP because it's too many hours, or et cetera. So them saying, for example, them saying that they don't need any more care or that they're doing better may not actually be accurate.
Yeah.
So how would you really be able to track that?
You want to take Therapeutic Alliance and then?
Yeah, sure.
Good.
Yeah. The Therapeutic Alliance, like the kind of similar to the other assessments, is really coming from the view of the patient, and there's specific questions that are asked that essentially pull out general feelings towards the therapist, as well as how comfortable the patient is.
Yeah, so this scale has a validated subscale, if you will, that tracks Therapeutic Alliance. It's been studied in, psychological research settings and all the rest of it.
So there's a normative data set for all of everything that's being tracked, and it's compared to that normative data set.
And then, I want to get over to Deja in a minute. Can you hold that, or? Because I also want to get to your question that seemed implied in there about how this all links up with payment and authorization and managed care overlay. But so with that said, thank you very much, Kate. And now, Dr. Gilbert will talk about sort of the work in progress that we have at Harmony, using sort of what I'd call a next generation set of outcome management tools.
Thank you. As Jerry mentioned, I'm the CEO of Harmony Health Group, and we are primarily a PHP intensive outpatient program. However, we are growing and expanding and have now started servicing residential. So as we took a look at this topic in particular and what outcomes look like and what systems we want to use, the key component is that there's a disconnect, not just among healthcare, but in behavioral healthcare in particular. Healthcare, say a cardiologist, you go in for surgery, the surgery is either successful or not. That's a very easy to measure outcome. When you look at behavioral healthcare, our industry is still relatively new to the space, to the healthcare space. And so initially, what we saw, I'd say 5-10 years ago, is a lot of individual groups coming out. And I actually read an article recently. It was the song by Tina Turner, Simply the Best. So we had this era for about 5-10 years ago where everyone was publishing outcomes. And they were simply the best of the best, and make sure you come to us for treatment. But they weren't validated, they weren't strategic, there was no data set that they were based off of. They were measuring internally what their perceived outcomes were and publishing those. So when we as a company looked at how are we going to take this to the next level, how are we going to solve for population health, how are we going to look at this disconnect amongst the industry, we needed a solution that was comprehensive, was validated with data, and was able to not just add a single system to the plethora of systems that we all use when we're operating a healthcare company, but would also add on and tie into a few other areas that we needed a solution for. And so as we looked at those solutions, I'm going to skip here. We had conversations with a company called UHealth. And the appeal initially with UHealth, from an operations standpoint, from a medical and psychiatric standpoint, was that we were looking and going to be able to look at the entire lifetime of the client. It's not just while they're in care. The application of it starts while they're in care, but it will continue with them indefinitely, as long as they're voluntarily opting into the system. And what it does is it solves for the longitudinal challenges of outcomes. Again, going back to the cardiologist, a cardiologist is successful and has positive outcomes if the surgery is successful. But when that patient leaves and is checked out of the hospital, are they eating better? Are they exercising? Are they integrating practices that are not going to end them back in the hospital? We're not tracking that. We're not looking at that. We're starting to, but the surgeon can certainly advertise that they are simply the best, but are they? Are they taking the time with that patient to follow up, to make sure that the diet has changed, to make sure that these things, again, looking at population health, are improving? This is what our patients want. They want to be better. They want to feel better. They're seeking care. And I do feel it's our responsibility to help them through that journey, not just while they're in our doors or while they're sitting in front of a therapist or a psychiatrist or a medical practitioner, but indefinitely. So what we did when we were looking at this is we began to start to implement it at Harmony Health Group. And so initially there was that response from the practitioners. Is this going to be more work? Is this going to be helpful? Is this just another system that we have to integrate and use? And so far, we have seen a great acquisition of all of these aspects. We not only are using it for outcomes, which are to be able to measure how are our therapists doing in comparison, how is our care, but also what support is involved with that individual. There is a module that, this is the key information that really captures the essence of you, and that we're able to integrate in the family, we're able to integrate in alumni services, we're able to integrate in the patient's own environment for seeking support, peer support, post-treatment, and we're able to engage them on a therapeutic level indefinitely. The platform itself, one of the challenges historically with outcomes measures and some of the systems that exist, such as Acorn, is that they are heavily reliant on self-report, which can be biased. So the benefit is that they have the historical data to kind of be able to determine how this patient's doing and make an intervention when necessary. But what U does is it actually tracks not only their self-report, because that is very important, but it's tracking things like, where did they go today? And we'll get into that in a minute. Are they at their therapist appointment? Are they at their primary care appointment? Are they at the bar? These are things that the system will actually track for them. And then it has features, again, it's its own environment. So there's features such as a patient, I can log in and I can write in a journal. That journal is going to be interpreted by the AI system that's backing up the entire platform and be able to say, hey, we're tracking this. We're noticing this individual isn't doing follow-up appointments. We're noticing that in their journal entries, they're slightly changing the tone in text. And so it will send an alert to whomever is involved with that patient at that point in care, their spouse, their loved one, their therapist, the treatment center that's tracking them for alumni services, and it allows us to engage the client ideally before they continue to deteriorate to a point where they have to return to a higher level of care or they're in an acute setting. And so all of these components work together. One of the things I wanted to circle back to is there's a lot of people who get concerned with this, privacy. If the patient doesn't want to engage in this, which we've actually seen Not the case, because they're already there in treatment. So for them to engage in a continuous care line is a natural step for them. They understand that. We're in an age right now where if I want to buy a new pair of pants, I might disclose to whomever on the internet my height, weight, biometric information, my preference and style, and all that data everyone knows is being compiled because the next ad that pops up on your screen is for that perfect pair of pants. But we're not using it in healthcare? That makes no sense. So to explain and to educate to the client, you can opt in or out, it's your choice. You can choose to share your data with whomever you want or no one. You can use it for yourself only. But if you want to share it, your therapist, who you already have an alliance with, will be on the other end. Your peer group, who you have a support network built into, will be on the other end. And most everyone we're seeing already, they want to be better. They want to feel better, so they are opting in. To share just 10% of these pieces of information are not scary to the general public right now. It is a valid concern, but it's built with ability to monitor. And so really taking a look at this system for us was the AI technology that is just incredible, the information that we can gain to better serve and better help our clients leads to better outcomes. And our perception of outcomes isn't just from door to door. It's the lifetime value of that client and making sure that their quality of life has improved and that if it's declining, we can intervene. And so those are the things that we really looked at. Those are the things that we are now implementing and that are critical for our population health and for our patients to actually be able to complete treatment but have a lifelong journey of recovery.
Got it. Thank you. Thank you. Yeah, so let me just bring it together. I'll come right back to you. So I think what you've heard, or the things that I heard and that are important are, to pick something, if you decide to do this, and I encourage you all to think about it, to pick something that has some valid scientific foundation, right? So you're not just asking the old days of the random phone calls and saying, are you abstinent? The patients who answer the phone and answer the questions are typically going to say, sure, yeah, of course I am. So you don't do that.
With
you use
wine
valid.
in hand.
What's that?
With wine in hand.
With wine in hand during the cocktail hour.
Yes.
So instead, though, you use scientifically validated tools that are easy to use. That's the other trick, is sort of at the point of care and beyond. You want to be delivering these things to patients, clients, consumers, so that they reliably get you the information back. And then you've got to bind it together in your treatment community so that, as Deja said, when somebody begins to decline, you reach out. When somebody's doing well, you reach out. And then the implication of one of the other questions becomes, what's next? So it's the so what question. So what? You've done this. You know that you get better results, et cetera. I think it sets the stage for what you're hearing about in some of the other panels here, value-based purchasing. It's what we tried to do when I was at United and Pacificare, was instead of paying for volume, pay people for outcomes, and I think that's kind of the triple aim goal that we all want to get to. And so I think there will come a day where managed care companies begin to pay, and they're already rewarding programs for doing certain process things, offering MAT to an SUD population, things like that. But I think down the road, it's entirely within bounds to see payers paying more for better outcomes. So, and then you had a question back there.
You mentioned AI earlier.
Yep.
Thank you. You mentioned AI earlier. This is a closed system right here. This is
Yep.
your data.
Correct.
Okay.
Right.
Do you use AI to pull some of the ACORN data in as well? Because it's a large enough universe, you can actually make statistical determinations based on that information. Can you, based on this closed model and the predictive studies from ACORN, make decisions based on that? Or is that what you're using AI for? Is that where you're pointing the data, or just within this closed system?
Let me clarify, and then I think the Acorn specific. With the U system, one of the reasons that we also chose it was because it did have a strong database. There's over, I believe, 1 billion data points right now already collected in the system. And so when we're using it, the AI is pulling from those data point systems to be able to predict, to be able to say, this doesn't add up, and so you might want to do an outreach. So yes, there is a back subset. It is not the Acorn subset, so that's why I would defer on that question specifically, but it has been, there's a lot of companies right now with outcomes platforms, and one of the things that we were very tuned into was, what is that data subset, so that we can actually have validated information, so that we can take to insurance carriers that we have true outcomes data and be able to use that in a conversation.
Yeah, so to compare the systems, I think the way I'd see it is that there are 2 lab tests, if you will, each measuring a certain profile of things. They're not yet interdigitating and sharing and sending information back and forth. But at some point in the future, could you, for example, look at therapeutic alliance from the 2 of them and compare data and have some independent data set? Yeah, absolutely. So yeah,
that would be the goal.
In the future, for sure. Other questions, comments? Anybody decide they might want to do this? Not so much? Yeah.
Predictive value. Are you able to predict someone's likelihood of relapse? The ability to predict whether someone might relapse or not. Are you finding this effective tool?
Yes.
Yep, absolutely.
That's actually key to what we're using. So in the system, a therapist has their own access, their own view of really any patient that has engaged with them. And they're able to see on a daily basis, on real time, whether that client's data is trending positive, trending negative, and they're able to say, hey, I see X patient trending negative. I'm going to send a quick message over to them. I'm going to see if I move my schedule from Friday to Tuesday because it looks like they're having some challenges. Or I'm going to send a note to recommend they reach out to their peer support group. So all of those things are critical, and that's what the data is really purposeful to do, is to tell us and to predict when this person is starting to move differently on that path and be able to intervene.
Are you getting good buy-in from people as they're discharged?
We are. So the way that we've done it, again, a lot of companies will start at discharge with discharge, aftercare planning, things like that. What this system does is we actually integrate it week 1. And so there are kiosks in every facility that we have where every day the patient can start engaging with the software. They have a profile set up by their primary care or whomever's assigned to that. And they're able to go in every day and start using the system. So by the time they're finished with care, they're already comfortable with it. They're already using it. It moves from a kiosk to a phone. And so that is key to buy-in, I think, is to making sure that during those initial times when they have a lot of support, when they're typically in a higher level of care and they're just starting out, that encouragement to use the system, the encouragement to get the value that they also, there's databases of education, there's communities of support, they're able to start appreciating that while they're still in care. So that post-care, that trend will continue and will continue to engage that client indefinitely.
Yeah, so both systems will do that. Both systems will predict during and outside of treatment when a relapse is likely. Acorn has been publishing for 20 years looking at within treatment, is treatment hitting the right trajectory in a risk-adjusted way, meaning somebody comes in really sick, they should be improving at this rate over time. And so those predictive abilities have been baked into these systems. And, I think down the road will show real value. That's why I get excited about value-based purchasing. I see a lot of activity there. Are we out of time?
We are over time, actually.
There we are. All right, thank you for your attention.
Thank you very much.
And contact the two of them or me if you have interest.